I'd like to welcome Professor James Larkin, who's a consultant medical oncologist from the Royal Marsden NHS Trust in London. He's going to talk to us about kidney cancer diagnosis and what happens when you are referred to an oncologist to have tests done for kidney cancer. So first of all, James, can you describe to me the usual tests that someone would have if they were referred to you with suspected kidney cancer?
Yeah, thanks, Sharon. Hi, everyone. There's lots of different ways that people come, I think, first of all, to say with a suspected diagnosis of kidney cancer. Some people may have already had other scans, like an ultrasound, for example, of the abdomen with their GP to investigate abdominal pain or other issues. And sometimes that can throw up concerns about the kidneys. And so I think the main test that we would use to diagnose kidney cancer would be a CT scan. It might start off as a CT scan, let's say, of the abdomen. But if we were to pick up a problem with the kidney, we would always want to do a CT scan of thorax, that's the chest, and abdomen and pelvis to look for potential spread, because we know that some people who've got kidney cancer, the disease is already spread actually when it's first diagnosed. That's probably sort of 15-20%. So CT is the main scan that we use. But in addition to that, we sometimes use other scans such as MRI, but maybe we could talk about that a bit.
Yeah, I was just going to ask, what do you think are the best types of scan to use, MRI or CT, for picking up kidney cancer?
Yeah, well, the answer is CT still.
Right.
Different scans, different tests have different characteristics. So there are some parts of the body that are better looked at with MRI. There are some parts of the body actually that are better looked at with ultrasound scans, for example, sometimes even traditional X-rays. So I think it's wrong to think about any particular test being superior to any other test. It's all about the ability or the characteristics of the test to help make a diagnosis. And so that will vary.
What is the smallest size of metastasis that you can pick up on a CT scan?
Probably CT is most sensitive for picking up abnormalities in the lungs. And you can pick up abnormalities in the lungs of only a few millimeters in size, 2, 3, 4, 5 millimeters in size, something like that. Other parts of the body, actually, it's a bit more difficult. And so you might only reliably be picking up things over, say, 5 millimeters in size or even 10 millimeters in size. So again, it comes down to the characteristics of the test and the performance of the test and looking at different parts of the body.
Can you tell me why sometimes follow-up scan results take up to about 6 weeks for people to receive them?
Yeah, that's an issue about reporting the scans. The images need to be interpreted by a radiologist, and that's a specialised job. It requires years of training to do it. And, it's difficult to sort of answer that question generally, but ultimately reporting scans comes down to the time of the radiologist to report the scans. And many radiologists at many hospitals will be dealing with emergencies and all sorts of other things.
Yeah.
So I think that's probably the main reason that sometimes the reports of scans can be delayed.
Yeah, because as you can appreciate, that's very concerning for patients having to wait
Absolutely.
that length of time. Follow-up regimes, why do they differ around the country? Some patients don't seem to have a great deal of follow-up. Some have follow-up scans every 3 months. Some have follow-up scans every 6 months. And follow-up lasts for between 2 and 10 years. Is there any reason for that? Is it just personalisation of the patient's type of cancer?
First thing to say is that we don't have really strong evidence from trials about how often we should be doing scans. And so some of this will depend on the risk of the cancer coming back. This is, for example, after someone's had surgery or something like that. But for most of the last sort of 10 years or so, we and others have been involved with doing adjuvant studies. So asking the question, would having drug treatment after surgery reduce the risk of the cancer coming back? So what we've tended to do to make things easier to understand and more straightforward is in people who aren't going into the trials for whatever reason, but there's still a risk of the cancer coming back, we try and give the same frequency of scans so that basically everyone's in the same boat, whether they're in the trial or not.
Why is it not standard practice for patients to be offered their scans actually copies of their scans and copies of their letters about their scans, written reports.
In our practice, we certainly do offer people copies of their letters, and we certainly do offer people copy of their scan reports if they wish to have them. I would just slightly caution about scan reports. They're written in technical language.
Yes.
As an interpretation of the scan. So sometimes they're not straightforward to interpret or understand. But when someone has a consultation, with their clinician, and the scan result is part of that consultation. So normally the clinic letter should include a comment about a scan result if someone's just had a scan. So I think personally, clinic letters, they're not everyone's cup of tea, but I think they can be helpful. We routinely offer everyone at the Marsden the opportunity to get copies of their clinic letters if they wish.
One of the questions that we get asked quite a lot is why people aren't offered regular brain scans to look for brain metastases from kidney cancer.
Yes, this is a good question. So one comment is that in kidney cancer, spread of the cancer to the brain is relatively rare, certainly in comparison with some other types of cancer. I treat melanoma as well as kidney cancer.
Yeah.
And spread to the brain in melanoma is unfortunately very common. And so there's, very clear international consensus that people should be offered brain scans. That actually isn't the case with kidney cancer. It's not just a UK thing. There's an international consensus there. Generally speaking, we will not offer routine brain scans. Nevertheless, if we're concerned for whatever reason about the brain, then it's absolutely something that we would think about, and we do. For me, that's what the whole thing about doing tests, whether it's scans or blood tests or anything else. The question is it going to yield useful information or not? Having scans causes anxiety apart from anything else. And so, there's a lot of things to think about there. But again, what I would say is it should be personalised for people.
Yeah, I mean, you've just preempted one of my questions, which was why don't people have more bone scanning? And if it's known that they have metastases in their limbs, in their bones, in their limbs, why aren't they CT scans used to look at the limbs as well?
Well, that's an excellent question. And the fact of the matter is that a bone scan can be a useful test to diagnose spread to bone metastases, but it is not a useful test for monitoring. Most people who've got spread of kidney cancer to the bones in the arms or legs will have some symptoms such as pain. And in that situation, I'd probably think about an X-ray. Actually, probably the most accurate test for the arms and the legs is MRI. But again, it's not going to be right or practical to be doing routine scans of the arms and legs in everybody. It's a question of picking the right test, I think, for the right patient in the right situation.